Welcome again to Imperial College Healthcare, and we're on our St Mary's site today, so the environment is slightly different from our previous filming. And I've got with me Ricardo Petraco, one of our consultants. Now, Ricardo's been revising our acute coronary syndrome protocols, given that we're in a very different COVID-19 environment. So, Rick, you've done a lot of work on that. Thanks for joining us.
Thank you, Rico.
So, can you put in a nutshell what is different from the way we were working 3 months ago in terms of acute coronary syndromes?
Sure. So I think that the COVID crisis has obviously affected us, particularly our acute care. And if we divide the presentation in two types, STEMIs and ACSs, the way that the COVID affected us is predominantly on the timing for angiography and on decision-making angiography, and on the length of hospital stay for these patients. So one of the things that we reconsider now out of the old age is thrombolysis. So patients coming with a STEMI, if they are, for example, infected with COVID, and that is their main clinical problem at the time, whether you bring them to the lab immediately to offer reperfusion or you offer reperfusion with lysis and stage that angiography for a later day is the main change in the STEMI pathways that we implemented. We are not saying either way, they should always do one or the other, but we put that out there for people to think and make the decision. And also help us to revise and remind us of doses of thrombolysis, side effects, and so on, because none of us are really up to date with that.
So the protocol you produce has the doses of the thrombolysis on, which is really useful because I certainly wouldn't have remembered them. Actually, we haven't taken that much thrombolysis on board. The two that I can recall were on intensive care unit already on a different site with temperatures nearing 40 degrees, where you have to question whether transfer was safe and whether any reperfusion was going to be effective. So they got thrombolysis and unfortunately didn't do very well. I'm also aware of one case where thrombolysis was done in one of our linked hospitals, achieved reperfusion in someone who wasn't immediately ready for transfer. So it's working, and we know that it can work. And perhaps we've forgotten that the absolute benefit is about 1% with primary angioplasty. So we're not really talking about earth-shattering changes. So what about making this difficult decision? Perhaps we can finish on how we can protect ourselves from the patient's family, litigation, if we've really gone against what was up till now absolutely standard practice, which is no to thrombolysis and yes to primary angioplasty. How do we protect ourselves?
Absolutely. So we are essentially deviating from guidelines largely. And when we do so, we have to make sure that we do it as a department, as a unit, rather than as an individual making decisions overnight. So the first thing I think we recommend is actually put this in writing in your hospital, making sure that it's actually part of your new pathway, potential for thrombolysis. And the second thing is don't make these decisions by yourself, and call a colleague that can support you or disagree with you on that decision. And these days, no one is away. Everyone is so much 24/7 on call. Everyone will be very happy to be called and discuss a case like that in the middle of the night. And that gives you that clear documentation that you've made the decision with a colleague rather than by yourself.
Fantastic. And I think the key is documenting it. So we've had the discussion and we've agreed that this is what we're going to do. It has to be written down somewhere at some stage. And luckily, we've got an electronic system that we can write it down in. But wherever it's recorded, it has to be recorded. So Rick, thanks very much for joining us, and keep up the good work.
Thank you, everyone.